This question is asking each of the following is a correct statement related to genetic testing except one. Which one is the exception? Testing is available for diseases arising out of genetic mutations and chromosomal abnormalities. Commercial testing kits are available on the market to test complex diseases. Patients with mysterious disease symptoms can apply to the Undiagnosed Diseases Network, or UDN, and most genetic tests are regulated by the U.S. Food and Drug Administration, or FDA. Now, this may have been a difficult question, and you may think you know nothing about genetic testing, but you're actually likely more familiar with it than you think. If we look at our answer choices, we're not only talking about the genetic testing that may be done at a doctor's office or for those with a known genetic condition, but we're talking about the commercial genetic testing kits that are direct to consumer as well. So these tests are the ones that you're likely familiar with, and they include companies or tests like Ancestry.com or 23andMe, where you swab your own DNA and send it back to a company to determine what genetic conditions or predispositions you may have. And for someone who is not currently experiencing the complicated symptoms of a genetic condition or is not having children, these direct-to-consumer tests may be the only genetic testing we undergo throughout our lives, at least to this point with the technology that we have. Now, although genetic testing used to be a very difficult task, advancements in this technology have made it a pretty common practice for a number of health conditions. I've definitely had my DNA tested with these at-home kits, and a number of people I know have done the same. As far as more advanced genetic testing, this is typically reserved for more rare and undiagnosed genetic disorders, or to let people know that they are a carrier for specific conditions when trying to have a child. These conditions may require whole genome sequencing or karyotyping, which are not available in a direct-to-consumer kit. Now, as far as these answer choices, the one that would be an incorrect statement is actually D, the fact that most genetic tests are regulated by the U.S. Food and Drug Administration. And this may have been tricky. Some of these tests certainly are regulated, especially the more complex ones that are administered in a doctor's office or lab. However, most genetic tests are definitely not regulated by the FDA, especially when it comes to direct-to-consumer tests. These tests do not undergo the same level of regulatory scrutiny as clinical diagnostic tests do. And that is why if you ever use any of these companies to test your DNA, they always advise you to follow up with your doctor to make sure your results are correct. And they also make you sign a bunch of agreements saying that your results may not be perfectly accurate. So although this is the only incorrect statement listed, let's still go over the other answer choices briefly. And we'll start with testing is available for diseases arising out of genetic mutations and chromosomal abnormalities. Now, this statement is absolutely correct and actually describes a large percentage of the genetic testing that is done. Conditions caused by a genetic mutation, such as cystic fibrosis or sickle cell anemia, are tested by comparing the patient's mutated gene sequence to a normal gene sequence to see what exactly is causing the mutation. Chromosomal abnormalities, such as Down syndrome and Turner syndrome, can also absolutely be tested for through something known as a karyotype, which involves examining all of the chromosomes for the correct count and presentation. So because this answer choice is absolutely true, because this statement is absolutely true, we know that this answer choice is incorrect. Next, we have commercial testing kits are available on the market to test complex diseases. Now, we already talked a whole bunch about how this is definitely true. Although these commercial testing kits obviously can't test for all complex diseases, they certainly can test the genetic likelihood for things such as type 2 diabetes, Alzheimer's, breast cancer, and heart disease. Just keep in mind that these tests are helpful and interesting for sure, but are certainly not perfect, and a genetic test done by a doctor or in a lab will likely have more precise results. But because these definitely are available, I've done some myself, we know that this answer choice is incorrect. And finally, we have patients with mysterious disease symptoms can apply to the Undiagnosed Diseases Network, or the UDN. This is something that we didn't touch on earlier, but it's definitely true. This network is a national research initiative that aims to help individuals with undiagnosed medical conditions. This network connects patients with healthcare professionals, researchers, and geneticists to try and identify the underlying causes of mysterious or rare diseases that do not fit typical diagnostic patterns. This is mostly designed for patients who have had extensive diagnostic testing already, but have not received a definitive diagnosis, such as those with extremely rare conditions or unexplained symptoms that defy traditional diagnoses. Patients can apply for this program and are typically referred by a healthcare provider to do so. And since this is another true statement, we knew that this answer choice was incorrect. So when talking about genetic testing, it is important to keep in mind that most genetic tests, especially the ones that are direct to consumer, are not in fact regulated by the U.S. Food and Drug Administration, or FDA. We have a 6-year-old female whose mom says, "My daughter's teeth are unsightly. Her siblings have similar looking teeth, and she's a friendly patient." And we notice pitted surfaces seen across the enamel of all teeth, and the condition has been diagnosed as type 1A hypoplastic amelogenesis imperfecta. And we're asked, what inheritance pattern does this condition display? Autosomal recessive, autosomal dominant, X-linked recessive, or X-linked dominant? So the good thing about this question is that we don't even have to try and figure out what condition this patient has. The patient box tells us that she has that type 1A hypoplastic amelogenesis imperfecta. Now, before we talk about the inheritance pattern of this condition specifically, let's first talk about these different inheritance patterns that we see in these answer choices, and then we'll talk more in depth about amelogenesis imperfecta as a whole. So autosomal dominant means that the child only needs to inherit one mutated gene from one parent to have the disorder, while autosomal recessive means that they have to inherit two mutated genes, one from each parent to cause the disease. If a condition is autosomal recessive, it only needs to inherit one mutated amelogenesis imperfecta as a whole. So autosomal dominant means that the child only needs to inherit one mutated gene from one parent to have the disorder, while autosomal recessive means that they have to inherit two mutated genes, one from each parent to cause the disease. If a condition is autosomal recessive, a person may also be a carrier for the disease, meaning they carry one mutated gene but do not present with symptoms of the disease. But if they have a child with another carrier, then that baby can inherit the two carrier genes and have the recessive condition. X-linked conditions are caused by mutations on the X chromosome, specifically a sex chromosome, and although that means they can technically affect both males and females, they're much more common in males because they only have one X chromosome and cannot rely on their other copy. In X-linked dominant conditions, affected males will pass the trait to all their daughters, while in X-linked recessive conditions, affected males will only pass the trait to their daughters as carriers. And now that we understand all of these inheritance patterns, let's discuss amelogenesis imperfecta. Now, this is a group of uncommon genetic disorders affecting the enamel of the teeth. This condition has varied patterns of inheritance and affects both the primary and permanent dentition. There are three main divisions of this condition: hypoplastic, which is inadequate deposition of the enamel matrix; hypomaturation, which is incomplete mineralization; and hypocalcified, which is no significant degree of mineralization. Hypoplastic would be the most severe, while hypocalcified is the least severe, and we see that our patient has the most severe or unsightly form. Clinically, this condition is characterized by rough, pitted, pigmented, or no significant degree of mineralization. Hypoplastic would be the most severe, while hypocalcified is the least severe, and we see that our patient has the most severe or unsightly form. Clinically, this condition is characterized by rough, pitted, pigmented, or snow-capped enamel. Radiographically, we see thin enamel of normal or decreased density with normal root and pulp morphology. The clinical implications and management vary according to the subtype and severity. Now, as far as the 1A hypoplastic variant of amelogenesis imperfecta, it has B, an autosomal dominant inheritance pattern. Just to reiterate, this means that only one chromosome with this mutated gene needs to be inherited for the patient to have this condition, which also explains why her siblings have similar looking teeth. It also means that either mom or dad will also have these unsightly teeth. Now, although this condition is definitely seen in this autosomal dominant inheritance pattern, let's quickly reiterate the other inheritance patterns and why they're incorrect here. We'll start with autosomal recessive. Now, this answer choice is incorrect because it only takes one copy of the mutated gene for a patient to have this type of amelogenesis imperfecta. And in autosomal recessive conditions, two mutated genes are required to be inherited for a patient to have the condition. And it's much harder to trace the condition down a family line, as some people are asymptomatic carriers. It would also make it less common to see among siblings, as it would affect a lower population of the offspring. Some examples of autosomal recessive conditions are cystic fibrosis and sickle cell disease. Since we know that this patient's form of amelogenesis imperfecta is inherited via an autosomal dominant pattern, we knew that this answer choice was incorrect. Next, we have X-linked recessive. Now, this answer choice was we knew that this answer choice was incorrect. Next, we have X-linked recessive. Now, this answer choice was definitely incorrect. That this answer choice was incorrect. Next, we have X-linked recessive. Now, this answer choice was definitely incorrect because the condition is not inherited via a recessive pattern, and the affected gene is not located on the X chromosome. The gene that is mutated in amelogenesis imperfecta is known as the ENAM gene, like ENAM gene, and it's located on chromosome 4. But some examples of X-linked recessive conditions would be hemophilia A, hemophilia B, and muscular dystrophy. And since once again we know that this patient's form of amelogenesis imperfecta is inherited via that autosomal dominant inheritance pattern and not X-linked recessive, we knew this answer choice was incorrect. And finally, we have the reason as the previous answer choice. The mutated gene that causes amelogenesis imperfecta is not located on the X chromosome. But some examples of an X-linked dominant condition is the Fragile X syndrome, which is a condition that causes intellectual disabilities. These are not as common as X-linked recessive conditions. So, to reiterate, we know that when discussing type 1A hypoplastic amelogenesis imperfecta, it is inherited via an autosomal dominant pattern, meaning only one copy of the mutated gene needs to be inherited. Finally, we have X-linked dominant. Now, this answer choice is incorrect for the same reason as not located on the X chromosome. The gene that is mutated in amelogenesis imperfecta is known as the ENAM gene, like ENAM gene, and it's located on chromosome 4. But some examples of X-linked recessive conditions would be hemophilia A, hemophilia B, and muscular dystrophy. And since once again we know that this patient's form of amelogenesis imperfecta is inherited via that autosomal dominant inheritance pattern and not X-linked recessive, we knew this answer choice was incorrect. And finally, we have X-linked dominant. Now, this answer choice is incorrect for the same reason as the previous answer choice. The mutated gene that causes amelogenesis imperfecta is not located on the X chromosome. But some examples of an X-linked dominant condition is the Fragile X syndrome, which is a condition that causes intellectual disabilities. These are not as common as X-linked recessive conditions. So, to reiterate, we know that when discussing type 1A hypoplastic amelogenesis imperfecta, it is inherited via an autosomal dominant pattern, meaning only one copy of the mutated gene needs to be inherited. We have a 74-year-old male who says, I'm here to get my cavity filled. He has type 2 diabetes, he's a smoker with a 40-pack-year history, his blood pressure is high at 176/90, he's complaining of mental confusion and fatigue, and his skin appears powdery in his face, trunk, and extremities, and we can see that in this image. We're being asked, what is the most likely diagnosis? End-stage renal disease, systemic lupus erythematosus, hepatitis B, or hypothyroidism? Now, this is a great question, and we're given a lot of information to be able to determine the most likely diagnosis. The first most obvious clue is the fact that the patient's skin has this powdery appearance, appearing on his face, trunk, and extremities. The description of the skin appearing this way is very characteristic of a certain condition. So if you see this on a patient, you should immediately assume one of these answer choices. Although the other symptoms experienced by the patient are also good indicators of his condition, that confusion and fatigue, those symptoms are not exclusive to this diagnosis, so I would keep them in mind but not hyper-focus on them. I do want to also point out that the patient is experiencing a hypertensive blood pressure, while his background does not mention that he has hypertension. This high blood pressure is another more unique symptom or effect of what the patient is suffering from. The final additional clue that I want to point out is the fact that the patient also has type 2 diabetes. Beyond just the other pieces of information that we were given, the fact that he has type 2 diabetes is very helpful to know, especially because type 2 diabetes is the leading cause of what this patient is experiencing, which is A, end-stage renal disease. Now, end-stage renal disease is the final stage of kidney failure and is the point where the kidneys have lost nearly all of their ability to function. This means that the body can no longer remove waste and excess fluid effectively, and the patient will require dialysis or kidney transplant for survival. Beyond just type 2 diabetes, this can also be caused by chronic hypertension, inflammation of the kidneys, other genetic kidney diseases, blockages in the urinary tract, abuse of certain medications like NSAIDs, and conditions like lupus. Common symptoms include fatigue, weakness, confusion, or difficulty concentrating, like we saw in our patient, Plant for Survival. Beyond just type 2 diabetes, this can also be caused to function. This means that the body can no longer remove waste and excess fluid effectively, and the patient will require dialysis or kidney transplant for survival. Beyond just type 2 diabetes, this can also be caused by chronic hypertension, inflammation of the kidneys, other genetic kidney diseases, blockages in the urinary tract, abuse of certain medications like NSAIDs, and conditions like lupus. Common symptoms include fatigue, weakness, confusion, or difficulty concentrating, like we saw in our patient, edema, loss of appetite, shortness of breath, severe hypertension, like we also saw in our patient, decreased urination, and a powdery appearance of the skin known as uremic frost. This characteristic appearance is due to crystalline deposits in the skin that are made up of urea and other waste products that the kidney can no longer filter, and it's now attempting to be excreted through the sweat glands. Short-term treatment for this condition is dialysis, like we said, and the long-term ideal treatment would be a kidney transplant. And if treatment is not successful, then complications can include cardiovascular issues, anemia, infections, and other disorders. So although we know this is definitely the correct diagnosis for this patient based off the uremic frost, his hypertensive blood pressure, his confusion and fatigue, as well as his history of type 2 diabetes, let's still go through the other answer choices and talk about what each condition is and why it's incorrect for this patient. We'll start with systemic lupus erythematosus. Now, lupus erythematosus is the most common collagen vascular connective tissue disease in the US, and it comes in 3 forms, but we'll focus on systemic lupus erythematosus because that was the answer. answer choice here. This condition is much more common in females, and the average age of diagnosis is 31 years old. So not really what we're seeing for our patient. The condition has a waxing and waning nature, and the initial manifestations are typically a fever, weight loss, arthritis, fatigue, and general malaise. Oral involvement is seen in 5 to 25% of lupus patients, and these can present as lichenoid or nonspecific ulcerations on the palate, buccal mucosa, gingiva, and vermilion zones. This condition also typically presents with a characteristic butterfly rash in the malar or cheekbone area, and that's what you can see in this image. And diabetes, let's still go through the other answer choices and talk about what each condition is and why it's incorrect for this patient. We'll start with systemic lupus erythematosus. Now, lupus erythematosus is the most common collagen vascular connective tissue disease in the US, and it comes in 3 forms, but we'll focus on systemic lupus erythematosus because that was the answer choice here. This condition is much more common in females, and the average age of diagnosis is 31 years old. So not really what we're seeing for our patient. The condition has a waxing and waning nature, and the initial manifestations are typically a fever, weight loss, arthritis, fatigue, and general malaise. Oral involvement is seen in 5 to 25% of lupus patients, and these can present as lichenoid or nonspecific ulcerations on the palate, buccal mucosa, gingiva, and vermilion zones. This condition also typically presents with a characteristic butterfly rash in the malar or cheekbone area, and that's what you can see in this image. And that spares the labial folds. The condition also presents with skin lesions that flare with UV exposure in response to the photosensitivity. There are a number of other less common manifestations of the condition that can certainly be seen as well. Renal symptoms, like we said, lupus can lead to end-stage renal disease, heart issues, headaches, and hematologic symptoms. Because lupus can involve a number of symptoms and often presents very differently between patients, it can be hard to diagnose. Treatment varies based on the specific symptoms and presentations, and the prognosis is also dependent on what organs are affected. Now, we knew that this answer choice was incorrect for a number of reasons. Although lupus can contribute to end-stage renal disease, like we said, that does not mean that our patient is experiencing lupus. We do not see any of the characteristic signs or symptoms in him that we would see in a patient with lupus. He has no malar rash, no oral involvement, no skin lesions similar to those seen in lupus, no fever, weight loss, or general malaise. The symptoms that we are seeing in this patient are also not typically seen in lupus beyond the fatigue. Uremic frost is incredibly specific to end-stage renal disease and is not seen in lupus, and neither is hypertension or mental confusion. He's also not the typical demographic to be experiencing lupus, but is actually the perfect demographic to be experiencing chronic kidney failure, which that information isn't a deal breaker when diagnosing something, but something important to keep in mind. So because of these reasons, we knew that this answer choice was incorrect. Next, we have hepatitis B. Now, overall, hepatitis refers to inflammation of the liver, with hepato meaning liver, and it can be due to viral infections, alcohol abuse, medications, autoimmune conditions, and other toxins. In viral hepatitis specifically, we're discussing the 5 main hepatitis viruses, A, B, C, D, and E, which each is different and has unique symptoms, transmission, and outcomes. Hepatitis B specifically is likely the form of hepatitis that you're most familiar with, as it's the form we learn the most about in dental school. This is because it's one of the most common bloodborne pathogens we're exposed to, so hopefully you're also vaccinated against it. This infection can cause both acute and chronic liver disease. It's primarily transmitted through contact with infectious bodily fluids, such as blood and semen, and is commonly transmitted via sexual contact, the sharing of needles, or even exposure to contaminated surfaces. Because it is a form of liver disease, the symptoms include jaundice, jaundice, fatigue, loss of appetite, abdominal pain, and dark urine, with chronic hepatitis B also causing joint pain and even liver cirrhosis. Treatment for hepatitis B depends on if it is acute or chronic. Most adults will recover from acute hepatitis B without treatment and often only need supportive care. Treatment for chronic hepatitis B includes antiviral medications, but complications such as liver scarring or liver failure can occur. Although only 5 to 10% of adults will develop the chronic form of hepatitis B, it's still not a risk that should be taken, so it's very important to get that vaccine when possible. Now, we knew that this answer choice was incorrect because the two conditions present very differently. We're talking about liver problems and liver failure in comparison to kidney problems and kidney failure. Hepatitis B is something that someone catches, and there is no indication that this patient has contracted this infection. Hepatitis also presents very differently than end-stage renal disease beyond the similar loss of appetite and fatigue. If the patient had hepatitis B, they would present with abdominal pain, dark urine, joint pain, and the characteristic yellowing of the skin known as jaundice. There would be no hypertension, no mental confusion, and definitely no uremic frost. So because of this, we knew that this answer choice was incorrect. And finally, we have hypothyroidism. Hypothyroidism is caused by decreased thyroid hormone production, which can be due to an iodine deficiency, autoimmune destruction of the thyroid, such as in Hashimoto's thyroiditis, or ablation by surgery or radiation therapy. When it presents in infants or children, it causes cretinism, and when it presents in adults, it causes myxedema. Symptoms of hypothyroidism in adults include poor memory and concentration, fatigue, cold intolerance, weight gain, an enlarged tongue, constipation, and peripheral swellings. This condition is usually treated with medications like Synthroid that act as thyroid hormone replacement therapy, but if the dosage is not effective or if the patient does not receive treatment, they can experience a myxedema coma. This is the result of hypothyroidism not being effectively treated for a long time, and it's often triggered by an infection, cold weather, or trauma. Symptoms for this include extreme cold intolerance, drowsiness followed by an extreme lack of energy, and eventual unconsciousness. Because this is life-threatening, it requires emergency medical treatment. Now, we knew that hypothyroidism was not the correct answer, even though both can impact concentration or confusion, fatigue, and edema. In hypothyroidism, patients will also present with the characteristic cold intolerance and weight gain. Think of hypothyroidism as the whole body and metabolism slowing down. This could also be pretty easily diagnosed by taking a blood test to examine thyroid hormone levels. This also does not present with high blood pressure or cause anything like uremic frost, so we knew that this answer choice was incorrect. So we know that when we have a patient with a powdery appearance of the skin, their blood pressure is very high, and they have mental confusion and fatigue, they are experiencing end-stage renal disease, especially if they have a history of diabetes. We have a 9-year-old female whose parent says she woke up with one side of her face swollen. She has a 101-degree fever, she's had malaise for 2 days, she's currently presenting with that fever and fatigue and a loss of appetite, and she has unilateral enlargement associated with the parotid gland. Now, after evaluating the patient's signs and symptoms, the dentist concludes the patient is presenting with mumps. What is the transmission of this disease? Now, before we talk about the transmission route for mumps, let's just talk about this condition as a whole and how we knew that this is what the patient had. Now, mumps is a viral infection that is very contagious, and it's thankfully not very common today due to the prevalence of the MMP, or measles, mumps, and rubella vaccine. Symptoms of the infection will show up 2 to 3 weeks after exposure, and the first symptoms are typically fever, headache, muscle aches and pains, loss of appetite, and fatigue. The characteristic swelling of the parotid salivary glands usually begins within a few days, and the swelling can be unilateral, like our patient, or bilateral, and it may be accompanied by pain or tenderness as well. Complications associated with the condition occur when the virus spreads to other tissues in the body, and they can include decreased fertility, encephalitis, meningitis, pancreatitis, and hearing loss. There's no specific treatment for mumps, as most people will recover in 3 to 10 days, with any treatment given to manage the symptoms, such as pain relievers or a warm cloth for the swollen salivary glands. And how did we know that what our patient is presenting with is mumps, beyond obviously just the question telling us that that's what she had? We know it's mumps because she has that fever, that malaise, that fatigue, that loss of appetite, and most characteristically because she has a unilateral enlargement or swelling of the parotid gland. The reason this child has mumps is because she likely did not receive her MMP vaccine for whatever reason. But let's jump back to the question. How is mumps transmitted? Now, this viral infection is definitely contagious, and a person with mumps can spread it from a few days before their salivary glands begin to swell until up to 5 days after the swelling begins. And it is spread via the respiratory route, meaning a person will get it when they come into contact with saliva or respiratory droplets from the mouth, nose, or throat of an infected patient. This means someone can get it from a patient coughing or sneezing, that's why they say to cover your mouth, also from sharing drinks with a patient, or from things like kissing. Now, although respiratory transmission is the correct answer for this question, let's go through the other answer choices and discuss what they are and what types of conditions can be spread via that route. We'll start with fecal-oral contamination. Now, this type of contamination often occurs in overcrowded or unsanitary conditions. People often get infections spread via this route from the ingestion of food and water contaminated with fecal matter. This is the route of transmission for conditions such as hepatitis A and E, cholera, and typhoid, but it is not the route of transmission for mumps, making this answer choice incorrect. Another way for transmission is contaminated blood, and this can also be known as the parenteral route of transmission. Parenteral just refers to administration or transmission of something that does not occur via the alimentary canal, which is the entire route that food takes from mouth to anus. This word is commonly used to describe medications that are given intravenously or subcutaneously, but when discussing a route of transmission for a disease, it refers to the spreading of a condition by blood, contaminated blood. This route describes all those blood-borne pathogens we learn so much about in dentistry and do our best to avoid. So conditions that spread via this route of transmission include hepatitis B and C and HIV, but mumps is not one of these answer choices that is spread via contaminated blood. Finally, we have a fomite. Now, a fomite is an inanimate object that transmits a disease to you. Do not get this confused with a vector, which would be a living organism that transmits a disease to you. So vectors would include mosquitoes transmitting malaria and dogs transmitting rabies, while fomites would include contaminated countertops or hand railings. Fomites are one of the major reasons that we are sure to sterilize an entire dental operatory before seeing a new patient, because things can stay alive on these surfaces and contaminate them. Now, examples of conditions that can be transmitted via fomites include the coronavirus and the rhinovirus, but it does not include mumps, so this answer choice is incorrect. So we know that when we're talking about mumps, we know the route of transmission is respiratory, and it's not fecal-oral, it's not contaminated blood, and it's not via a fomite. This question is asking, what is the most common oral manifestation of tuberculosis? Multiple shallow ulcers, a solitary ulcer with verrucous mucosal hyperplasia, interdental papillae ulceration and necrosis, or a solitary and painful tongue ulcer. Now, before we talk about the most common oral manifestation of tuberculosis, let's just talk about tuberculosis as a whole. Now, this is a bacterial infection caused by Mycobacterium tuberculosis. It spreads via droplet transmission and is endemic in many areas of the world. But only about 5 to 10% of patients infected with tuberculosis, or TB, progress from infection to active disease, and this is often seen in patients who are immunosuppressed. Symptoms of a TB infection include low-grade fever, night sweats, fatigue, weight loss, and chronic bloody cough. To diagnose tuberculosis, a positive skin test is done to indicate exposure, but it can also be diagnosed via a chest x-ray, a culture, or molecular testing. Tuberculosis is treated via a combination of antibiotics, including isoniazid, rifampin, pyrazinamide, and ethambutol for 2 months. The prognosis is generally good in an immunocompetent patient, but problems arise when patients fail to take the prescribed medications properly. It's a lot of medications and you take them for a long time. Now back to the question being asked. Oral lesions as a whole for tuberculosis are rather uncommon, but the most common finding is a solitary chronic painful ulcer or granular lesion found on the tongue or sometimes the gingiva. This may be due to implantation of organisms, either directly or through the blood. This means that the correct answer would be D, a solitary and painful tongue ulcer. Although we know this is the correct answer and we can see an example in this picture, let's go through the other answer choices and talk about why they're incorrect. We'll start with multiple shallow ulcers. Now, this answer choice is incorrect because the ulcers seen in tuberculosis are not shallow or usually numerous. These ulcers are usually deeper, irregular, and also more painful. Multiple shallow ulcers is often seen in viral infections such as herpes, varicella zoster, which is chickenpox, and hand, foot, and mouth disease. And next we have a solitary ulcer with verrucous mucosal hyperplasia. Although the correct answer was a solitary ulcer, this answer choice is incorrect because tuberculosis lesions are not characterized by a verrucous or wart-like presentation, and they do not exhibit hyperplasia. A verrucous hyperplastic presentation is more common in verrucous carcinoma or chronic irritation of the mucosa, and in this picture we see an example of a verrucous carcinoma. And finally, we have interdental papillae, ulceration, and necrosis. This answer choice is incorrect because even though tuberculosis can cause a lesion on the gingiva, it will not cause ulceration of the interdental papillae or necrosis. This ulceration, or punching out of interdental papillae and necrosis, is characteristic of necrotizing ulcerative gingivitis and not tuberculosis. So when considering tuberculosis and its oral presentations, the most common lesion we see is a solitary painful ulcer on the tongue, which you can see an example of in this picture. This question is asking, each of the following are characteristics of Pierre-Robin syndrome except one. Which one is the exception? A cleft lip, a cleft palate, mandibular micrognathia, or glossoptosis? This is a pretty straightforward question that really requires you to know the characteristics of Pierre-Robin syndrome. So let's go ahead and talk about this syndrome. Pierre-Robin syndrome is an uncommon congenital birth defect characterized by a triad of conditions, and it's also known as the Pierre-Robin sequence. It is known as a sequence because one component or finding leads to the formation of another, which leads to the formation of the third condition. It's a series of events dependent on each other. The first event in the sequence is the underdevelopment of the mandible as the fetus develops. This underdevelopment prevents the tongue from growing and developing in the correct location, forcing it to be pushed up and back into the upper airway. And because of this location of the tongue, the palate is blocked and unable to obtain full closure, resulting in a cleft palate. And this is that triad of components associated with this sequence or syndrome. Underdeveloped mandible, leaving no room for the tongue, pushed back tongue, leaving no room for palate to close, a cleft palate, mandibular micrognathia, and glossoptosis, or displacement of the tongue in the far back of the mouth. That is what we're seeing: cleft palate, mandibular micrognathia, and glossoptosis. And because these three features make up 3 of our answer choices, even if we didn't know that A, cleft lip, was not a characteristic of Pierre-Robin syndrome, we could pick it as the correct answer just by process of elimination. Now, the exact cause of this condition is unknown, but there are theories that it may be due to increased pressure on the mandible or ill positioning of the head during fetal development, preventing that lower jaw from growing. Increased pressure on the mandible or ill positioning of the head during fetal development, preventing that lower jaw from growing. There may also be genetic mutations or genetic ties to the condition. The most immediate and concerning complications of this condition are the infant's ability to breathe and feed. The retruded tongue may block off the airway and make it difficult to breathe, while the underdeveloped jaw, tongue placement, and cleft palate can all impede feeding. Treatment varies for the condition depending on how mild or severe it is. Sometimes the mandible will grow itself over time and treatment may be unnecessary, but more severe cases require surgeries to allow for breathing and mandibular growth. Because the lip is not affected by that characteristic sequence of events seen in Pierre-Robin syndrome, we know that cleft lip is the correct answer here. We can quickly go through these other answer choices again, just to re-emphasize that they are characteristics of this syndrome. So we'll start with that cleft palate. We discussed how this is that third event that typically occurs in the sequence, and how the failure of the palate to close is due to the tongue being displaced. Because this is the third event, it is also the least common of that triad of symptoms and is only seen in 50% of cases. But it definitely is a characteristic of Pierre-Robin syndrome, so we know that this answer choice is incorrect. Next, we have that mandibular micrognathia. We also talked about how this is usually the first event in the triad. The mandible will be underdeveloped or smaller than is typical. This can be due to constraint of mandibular growth, possibly due to pressure in the womb or genetic mutations. But because it is definitely a characteristic, probably the most defining characteristic of Pierre-Robin syndrome, we know this answer choice is also incorrect. And then finally, we have glossoptosis, which we also talked about. This is displacement of the tongue in the far back of the mouth. And this is the result of the mandibular micrognathia, and it is the cause of the cleft palate. This also contributes to feeding difficulties and difficulty breathing in many infants. And because it is also definitely a characteristic of Pierre-Robin syndrome, we know this answer choice is once again incorrect. So we know that the main characteristics associated with Pierre-Robin syndrome are cleft palate, mandibular micrognathia, and glossoptosis, while cleft lip is not a characteristic of this syndrome. This question is asking which cells are abnormal in multiple myeloma: T cells, B lymphocytes, plasma cells, or eosinophils. Now this can be a really easy question as long as you know what multiple myeloma is, so let's talk about it. Now multiple myeloma is a cancer of C plasma cells, and it occurs when there is clonal proliferation of one specific immunoglobulin type that is not normal or functional. Now plasma cells are a type of white blood cell that develop from activated B lymphocytes, and they originate in lymphoid organs. These are end-stage immune cells that play a significant part in the humoral immune response and are responsible for secreting large amounts of specific antibodies or immunoglobulins. The class of antibodies produced and secreted by these cells depends on the signals they receive from T cells, and they can only produce a single kind of antibody, but each can produce thousands of these per second. These cells can be affected by a number of conditions, like autoimmune conditions and infections, but an increased number of them causes this cancer. Now, excluding metastatic disease, this condition accounts for 50% of malignancies involving bone and is mostly seen in those over 40. It's twice as common in males and twice as common in black males as white males, and this is actually the most common hematologic malignancy in black people in the US. Clinically, it presents with bone pain, especially in the lumbar spine, pathologic fractures, renal failure, soft tissue calcifications, fatigue, petechial hemorrhages of the skin and oral mucosa, fever, and amyloidosis, which is just the deposition of amyloid, and this is commonly seen in the skin and oral mucosa, with the tongue being the most common intraoral location for this amyloid deposition. Now, radiographically, widespread lytic lesions of bone are seen, as well as characteristic punched-out radiolucencies, often seen in the skull. Now, treatment serves to control the disease and keep the patient comfortable. It involves chemotherapy, a bone marrow transplant, and radiation, as well as palliative treatment. The prognosis, unfortunately, is pretty poor, with a survival rate of typically 6 to 7 years after the diagnosis. So because this condition is specifically a cancer of the plasma cells, we know that this is the correct answer choice. Now let's quickly go through the other answer choices and discuss what they are and why they are incorrect. Start with T cells. Now the two main types of T cells are the CD4 T cells and the CD8 T cells, which both play a role in the immune response. CD4 T cells are also known as helper T cells, and they serve to coordinate the immune response by stimulating other immune cells. Like I said, CD4 cells are the helper cells. They help out by triggering the immune response after recognizing certain pathogens and secreting signals to activate other immune cells. CD8 cells are known as cytotoxic T cells, and they're the cells that actually destroy infected cells. CD4 T cells are the main target in HIV, and CD8 cells are affected in many chronic immune conditions such as rheumatoid arthritis, Crohn's disease, lupus, Sjogren's syndrome, multiple sclerosis, and Graves' disease. But because these cells are not involved in multiple myeloma at all, we knew that this answer choice was incorrect. Next, we have B lymphocytes. Now, these B cells or B lymphocytes are another type of white blood cell that are essential to the immune system, especially in the body's adaptive immune response. They're derived from stem cells in the bone marrow and serve many roles, including antigen recognition and memory, antigen presentation, production of antibodies or immunoglobulins, and activation of the adaptive immune response. Several diseases or conditions can affect these cells, including autoimmune diseases like lupus and multiple sclerosis, and that's because B cells will actually produce autoantibodies as well, and also immunodeficiencies in cancers, and even infections such as certain herpes strains. I do want to point out that although plasma cells are derived from B lymphocytes, they are still the cells that are specifically abnormal in multiple myeloma. B lymphocytes themselves are not abnormal in this condition. So because these precursor cells do not give rise to this cancer, we knew that this answer choice was incorrect. And then finally, we have eosinophils. Now, these are a type of white blood cell that also play a key role in the immune system, especially against parasites and in allergic reactions. They also contribute to both acute and chronic inflammation and produce a variety of cytokines to help regulate the immune response. Conditions affecting these cells typically lead to an increase in their number rather than a decrease, and they include asthma, hay fever, parasitic infections like hookworms or roundworms, rheumatoid arthritis, eosinophilic esophagitis, eosinophilic pneumonia, and certain drug reactions. A decrease in the number of eosinophils is typically a sign of acute infection, corticosteroid use, high stress levels, bone marrow suppression, anemia, hypothyroidism, Addison's disease, and certain leukemias. But because these cells have no association with multiple myeloma, we knew that this answer choice was incorrect. So when talking about multiple myeloma, we know that this is a cancer of the plasma cells and has nothing to do with T cells, B lymphocytes, or eosinophils. This question is asking which is a common symptom of hypothyroidism: weight loss, tachycardia, irritability, or fatigue. Now, this is a great question asking about hypothyroidism, which is a pretty common condition that you're likely to see in your dental practice. Now, before talking about which is not a common finding, let's start by talking about hypothyroidism as a whole. Now, hypothyroidism is caused by decreased thyroid hormone production, which can be due to an iodine deficiency, autoimmune destruction of the thyroid, such as in Hashimoto's thyroiditis, or ablation by surgery or radiation therapy. When it presents in infants or children, it causes creep cretinism, and when it presents in adults, it causes myxedema. Symptoms of hypothyroidism in adults include poor memory and concentration, fatigue, thyroid, such as in Hashimoto's thyroiditis, thyroidism as a whole. Now, hypothyroidism is caused by decreased thyroid hormone production, which can be due to an iodine deficiency, autoimmune destruction of the thyroid, such as in Hashimoto's thyroiditis, or ablation by surgery or radiation therapy. When it presents in infants or children, it causes cretinism, and when it presents in adults, it causes myxedema. Symptoms of hypothyroidism in adults include poor memory and concentration, fatigue, cold intolerance, weight gain, an enlarged tongue, constipation, and peripheral swellings. This condition is usually treated with medications like Synthroid that act as thyroid hormone replacement therapy, but if the dosage is not effective or the patient does not receive treatment, they can experience a myxedema coma. This is the result of hypothyroidism not being effectively treated for a long time, and is often triggered by an infection, cold weather, or trauma. Symptoms for this include extreme cold intolerance, drowsiness followed by an extreme lack of energy, and eventual unconsciousness. Because this is a life-threatening emergency, it requires emergency medical treatment. And based off of everything we just talked about with this condition, it should be pretty obvious what the answer choice is, and that would be D, fatigue. Think of hypothyroidism as the whole body and metabolism slowing down. This is what causes the fatigue, the weight gain, the constipation, cold intolerance, and other symptoms we talked about. The body and the mind are sluggish and exhausted due to this thyroid hormone insufficiency, and that is why fatigue is a very common symptom, even if it may be a difficult symptom to diagnose just based off of. Now, when we look at all these other answer choices, we're looking at symptoms of hyperthyroidism, seeing as they are all basically the opposite of hypothyroidism symptoms. Hyperthyroidism can be caused by autoimmune conditions such as Graves' disease, thyroiditis, thyroid cancer, or excessive iodine intake. This condition is the complete opposite of the symptoms seen in hypothyroidism because it results in the speeding up of the body's metabolism. Tremors are a common symptom experienced by people with this condition, as is tachycardia, or an increased heart rate, weight loss, nervousness or anxiety, heat intolerance, irritability, increased sweating, and frequent bowel movements. A common complication of hyperthyroidism is a thyroid storm, which is a life-threatening emergency where the symptoms such as rapid heart rate and fever become severe and can cause organ failure. This condition can be treated by medications, radioactive therapy, or a thyroidectomy, but then the patient would just be back to dealing with hypothyroidism. So because out of these four options, fatigue is the only answer choice that is a symptom of hypothyroidism and not hyperthyroidism, we knew that it was the correct answer. Now let's briefly go through the other answer choices one more time. We'll start with weight loss. Once again, because this is a symptom of hyperthyroidism, this is the exact opposite of what we would see in hypothyroidism. In hypothyroidism, we would actually see weight gain as the metabolism is slowing down and more fluid is retained. So because this is the opposite of what we see in these patients, we knew that this answer choice was incorrect. Next, we have tachycardia. Because this is also a symptom of hyperthyroidism, this is the exact opposite of what we would see in hypothyroidism. In hypothyroidism, we would actually see bradycardia, or a slower heart rate, due to the decreased metabolism. Tachycardia is seen in hyperthyroidism due to increased sympathetic nervous system activity and cardiac output, but because this is not seen in hypothyroidism, we also knew that this answer choice was incorrect. And then finally, we have irritability. Now, this is also commonly seen in hyperthyroidism, and it's due to the effect of those elevated thyroid hormones on the nervous system. This irritability specifically is due to a combination of factors, such as increased sympathetic nervous system activity, disruption of neurotransmitter balance affecting mood regulation, and physical discomfort from other symptoms like tachycardia and heat intolerance that may lead to frustration. But because, once again, irritability is not commonly seen in hypothyroidism, we knew that this answer choice was incorrect. So we know that when talking about hypothyroidism, we know fatigue is a common symptom, while weight loss, tachycardia, and irritability are not. These three are instead common symptoms of hyperthyroidism. This question is asking each of the following is a possible feature of a patient presenting with ectodermal dysplasia except one. Which one is the exception? Hypotrichosis, frontal bossing, anhidrosis, or hyperdontia? Now, this is a great question testing your knowledge of ectodermal dysplasia, which is definitely a condition that you should be familiar with for your boards. This developmental condition is a group of inherited disorders in which two or more ectodermally derived structures do not develop normally, known as hypoplasia, or fail to develop, known as aplasia. This condition has several patterns of inheritance depending on the type and is characterized by hypoplasia or aplasia of the skin, hair, nails, teeth, and sweat glands. One of the most common types is hypohidrotic ectodermal dysplasia, which is more pronounced in males than females. Clinical features include fine, sparse, blonde or light-colored hair, periocular hyperpigmentation, heat intolerance due to lack of sweat glands, protuberant lips, prominent forehead, varying degrees of xerostomia, brittle nails, hypodontia or oligodontia, abnormally shaped crowns, and teeth with conical roots. Treatment for this condition includes genetic counseling for patients and parents and will likely include fixed, removable, implants, and orthodontics depending on the individual case. Now, based on everything we just said about this condition, it should be very apparent what the correct answer choice here would be. The feature that does not present in patients with ectodermal dysplasia is D, hyperdontia, or the presence of extra teeth. As we said earlier, this condition is characterized by hypoplasia or aplasia of ectodermally derived structures, which includes the teeth. Because of this, patients with this condition have less teeth than normal, certainly not more. They wouldn't have hyperdontia, they wouldn't have more teeth, they wouldn't have supernumerary teeth, they would have less teeth. They present with hypodontia, which is missing 1 to 6 teeth, or oligodontia, which is missing more than 6 teeth. So this answer choice is definitely incorrect. Next, we have hypotrichosis. We did talk about this earlier, but we didn't use this exact term. Hypotrichosis just means that there is little or no hair growth present. This is absolutely a feature of ectodermal dysplasia, as hair is an ectodermally derived structure. Patients with this condition will have fine, sparse hair that is often blonde in color if they have any hair at all. And because of this answer choice is incorrect. Next, we have frontal bossing. We also talked about this earlier, but didn't use this exact term either. Frontal bossing just refers to a prominent protruding forehead, and you can see that in this patient. This is definitely a feature seen in this condition, as well as many other craniofacial conditions, so this answer choice is incorrect. And then finally, we have anhidrosis. This is a final feature of ectodermal dysplasia that we talked about earlier, but did not use this term for. Anhidrosis is also known as hypohidrosis, which we did mention, and this is when the sweat glands make little or no sweat. This can lead to a number of complications, including heat intolerance, burns, and infections. Because sweat glands are ectodermally derived, anhidrosis is definitely a feature of ectodermal dysplasia, making this another incorrect answer choice. So when we are discussing ectodermal dysplasia, a condition affecting ectodermally derived structures, hypotrichosis, frontal bossing, and anhidrosis are common features, while hyperdontia is not. Instead, we typically see hypodontia, or a reduction in tooth number in patients with this condition. question is asking which condition can be a trigger for oral hairy leukoplakia: the Epstein-Barr virus, the herpes simplex virus, the varicella-zoster virus, or the Coxsackie virus. Now, before we talk about what is a trigger for oral hairy leukoplakia, let's first talk about what it is, and I've attached a picture of how it presents. Now, this is a lesion that is characterized by non-removable white plaques of the lateral tongue. This usually presents as vertical parallel lines that may be unilateral or bilateral. Most patients with oral hairy leukoplakia are HIV infected. Patients may be in other immunocompromised states, but it's just important to know that this is rarely seen in healthy patients. It's kind of an opportunistic viral infection. Now, most importantly for this question, oral hairy leukoplakia is caused by A, the Epstein-Barr virus, which is a relatively common virus spread through bodily fluids, especially saliva. It does not typically infect immunocompetent people, like we said, and it's usually seen in patients with HIV and other immunocompromised states. Although the other answer choices are incorrect, let's go through each one and talk a little bit about them and what conditions and presentations they are known to cause, since they do not cause oral hairy leukoplakia. We'll start with the herpes simplex virus. Now, this is a DNA virus that has two forms: HSV1, which is predominantly oral, and HSV2, which is predominantly genital. Initial contact with the virus produces a primary infection, but the virus can lay dormant in the sensory ganglia and become reactivated later as a recurrent infection. A primary herpes infection is also known as herpetic gingivostomatitis and is characterized by acute fever, cervical lymphadenopathy, and oral sores of the oral mucosa, as you can see in the image on the left. So on the left, we're seeing that primary herpes infection. Now, recurrent herpes can either be seen intraorally or on the vermilion zone or perioral skin. Recurrent herpes labialis is triggered by UV light exposure or trauma and is characterized by a cluster of vesicles alongside itching and burning. You can see how that presents in the picture on the right. So the right is a recurrent herpes infection. Now, recurrent intraoral herpes is pretty uncommon, but it's characterized by shallow ulcers on the periosteum-bound mucosa. And overall, what's important to also know is that this virus does not cause oral hairy leukoplakia. Next, we have the varicella-zoster virus. Now, this causes both chickenpox and shingles and is spread through direct contact or airborne droplets. Now, chickenpox represents the primary infection with the varicella-zoster virus and is characterized by fever, malaise, and cutaneous lesions that are often described as dewdrops on rose petals. These intensely itchy vesicles will rupture and form a hardened crust and can be seen in the picture on the left. Oral lesions can also be seen when a person is infected with chickenpox. Reactivation of the varicella-zoster virus causes shingles, which is characterized by painful erythema and vesicles on one side of the body, usually on the trunk, which you can see in the picture on the right. This reinfection can affect the head and neck and present with intraoral presentations as well. And once again, this virus does not cause oral hairy leukoplakia. And finally, we have the Coxsackie virus. Now, the Coxsackie virus is an enterovirus that is known to cause infections such as herpes angina and hand, foot, and mouth disease. Now, herpes angina is primarily seen in children 1 to 4 years of age and is mainly spread through the fecal-oral route. It is characterized by acute onset of sore throat, fever, and oral ulcers localized to the posterior soft palate and tonsillar pillar region. This can be seen in the picture on the left. Those lesions are only in that posterior soft palate and tonsillar pillar region. Now, hand, foot, and mouth disease is a similar infection and presents as a flu-like illness with sore throat and fever. It's different, however, in a way that is pretty obvious with its name. It's characterized by erythematous skin macules with a central vesicle that are found most commonly on the hands and feet. And you can see that in the picture on the left on someone's hand. Now, you can also see in this condition the oral lesions are shallow ulcers found on the buccal mucosa, labial mucosa, and tongue. So they're not localized to the posterior soft palate and tonsillar pillar region. And most importantly for this question, this virus also does not cause oral hairy leukoplakia. So when we're talking about oral hairy leukoplakia, which you can see in this picture, it is always caused by the Epstein-Barr virus and is often seen in patients with HIV or other immunocompromised states.